Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 537 of our pharmacotherapy series, which majors in anxiety disorders. The first case reads: DOD is a 42-year-old woman who was attacked and raped in the driveway of her home as she was getting out of her car 1 month ago. She did not seek medical treatment at the time and waited several days before reporting the incident to anyone, including her family. She presents to her physician complaining that she cannot sleep and she is irritable, anxious, and depressed. When asked about any recent stressor in her life, she finally tells her doctor about the rape. DOD has no history of psychiatric illness, admits her symptoms have appeared since the attack, and says she has never had any psychiatric problems until now. She states she has nightly nightmares and becomes extremely anxious every time she comes home and gets out of her car at night, which she avoids doing when possible. She is startled when the phone rings or when someone approaches her unexpectedly, and she literally freezes if she sees a man who bears any physical resemblance to her attacker. DOD also states that memories of the rape often flash through her mind for no reason, although she tries hard not to think about it. The assailant has not been caught, and DOD feels extremely guilty for not promptly reporting the crime. Her symptoms are interfering significantly with her ability to work and have put a strain on her marriage. What clinical features of post-traumatic stress disorder, abbreviated as PTSD, does DOD display? Individuals with post-traumatic stress disorder often present with nonspecific complaints indicative of a generalized anxiety, depression, or substance use disorder. They may not realize or want to reveal an association between their symptoms and the trauma experienced. Careful evaluation by the clinician is required to elicit a pattern suggestive of post-traumatic stress disorder. DOD displays many target symptoms of post-traumatic stress disorder, including re-experiencing intrusive symptoms, such as nightmares or recurrent memories, avoidance of the activity reminding her of the trauma, symptoms of increased arousal, manifesting as sleep difficulties, irritability, and exaggerated startle response, and negative alterations in cognition, that is, guilt. In addition, she is experiencing feelings of depression, distress, marital problems, and impairment in occupational functioning as a result of her symptoms. The lack of any previous psychiatric illness combined with the temporal relationship between the attack and her symptoms supports the presence of post-traumatic stress disorder as opposed to another anxiety or depressive disorder. Since her trauma occurred 1 month ago, her condition would be classified as acute onset post-traumatic stress disorder. The next question reads, what factors are important in the selection of an initial treatment for DOD? Because DOD is exhibiting moderate to severe post-traumatic stress disorder symptoms, pharmacotherapy is indicated. Medication treatment should be combined with cognitive behavioral therapy if it is available, but non-pharmacologic therapies alone are generally reserved for patients with mild symptoms. A selective serotonin reuptake inhibitor is the preferred initial medication treatment for most patients. Sertraline is an appropriate choice of treatment in this case and is FDA approved for post-traumatic stress disorder. Low initial selective serotonin reuptake inhibitor doses are recommended in post-traumatic stress disorder, so sertraline can be started at 25 mg per day and gradually increased to the target dosage range of 100 to 150 mg per day, according to response and tolerability. Persistent sleep complaints during the first month after a traumatic experience may predispose the patient to chronic post-traumatic stress disorder, so management of sleep disturbances is an important component of initial post-traumatic stress disorder treatment. If cognitive behavioral therapy for insomnia is available, this may be considered. The next question reads, what are the goals of treatment in this case, and how can DOD's symptoms be objectively assessed? The first goal of treatment of post-traumatic stress disorder is to reduce the core symptoms of re-experiencing, intrusion, avoidance, hyperarousal, and negative alterations in mood and cognitions. In DOD's case, these target symptoms include nightmares, intrusive memories, avoidance behaviors, irritability, hyperarousal, sleep difficulties, and guilt. Improvements should begin within the first 2 weeks and gradually continue over the course of 2 to 3 months. Secondary goals in this case include improving DOD's stress resilience, decreasing her work-related and marriage-related disability, and improving her quality of life. Other general treatment goals in post-traumatic stress disorder include decreasing detrimental behaviors, use of alcohol or substances, risky activities, violence, and treating comorbid psychiatric conditions. Several different rating scales have been developed to assess response to treatments in post-traumatic stress disorder. The most commonly used clinician-rated scales are the Clinician-Administered Post-Traumatic Stress Disorder Scale and the Treatment Outcome Post-Traumatic Stress Disorder Scale. The Clinician-Administered Post-Traumatic Stress Disorder Scale is most often used in clinical post-traumatic stress disorder trials. The Sheehan Disability Scale is often used to assess functional impairment attributable to post-traumatic stress disorder. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 538.